Okay, so for this chapter, which is chapter 5, we'll be discussing um, not just inflammation and healing, but we will explore normal defense mechanisms of our immune system and how that works. We will go over capillary exchange in relationship to its role in the inflammatory response. We will describe the local and systemic effects of inflammation. We'll talk about acute versus chronic inflammation and the different modes of treatment for inflammation. We'll also discuss how the body heals, and we'll go through some of the factors that can help speed up recovery or things that can delay healing and recovery. We'll talk a little bit about the different types of burns, classifications of burns, and the effects of burns and some of the anatomy involved. So let's first look at the first line of defense. The first line of defense, our first of three, is a non-specific mechanism. There is a mechanical barrier, and then we have these mucus barriers. So the mechanical barrier is our skin, right? That is our first line of defense. It is the first part of our security system, keep the invaders out. So we do have the skin, but then we also have mucous membranes. Think of the eyes, think of the tears that help protect the eyes and to clean out any debris. We have saliva. There are many important enzymes that we have in our mouth to keep things from entering deeper into our body. So the key with this first line of defense, it's really non-specific. It just targets anything that shouldn't be there. Now, our second line of defense is also non-specific, whereas our third line of defense is specific. So the second line of defense is non-specific, and our body can use phagocytosis, inflammation, and interferon as three non-specific mechanisms. Phagocytosis, we've heard this term before, right? We know that monocytes evolve into macrophages, and macrophages engulf and take away debris, but so do some of our other white blood cells. Remember, they were 3 granulocytes and 2 agranulocytes. So the granular cytes are the basophils, eosinophils, and neutrophils. The agranular one were lymphocytes and monocytes. But the granulations within those cells degranulate and release these very strong, potent enzymes to destroy the pathogen. So phagocytosis, cell eating, cleaning away debris. We're going to see this anytime there's been damage to tissue and we need to break away the old debris, take out the old, and bring in the new to help heal and recover. Inflammation is a non-specific mechanism, and we'll talk about the different components of inflammation shortly. And then we have interferon. Interferon is involved in protecting us against viruses specifically. Our third line of defense is a specific defense. This involves lymphocytes. Now, we'll show you shortly that lymphocytes can evolve and develop into B cells or T cells. B cells have the ability of producing specific antibodies, whereas our T cells act differently. They deal with cell-mediated immunity, which is very, very different than the B cells producing specific antibodies. So here's just a little illustration showing you on the left-hand side. This is showing like hematopoiesis, right? How blood cells develop. So from this stem cell up here, this multipotent hematopoietic stem cells can divide and differentiate. So we have the myeloid stem cell on the left and the lymphoid stem cell on the right. Notice the lymphoid stem cell can develop into a T lymphocyte or B lymphocyte. Our B lymphocytes can evolve and produce plasma cells. And these plasma cells here are the ones that actually produce antibodies. So on the last slide, it said B cells produce antibodies. Yes, indirectly. So B cells become plasma cells, and plasma cells can produce antibodies. Now on the other side, we've got these myeloid stem cells. Myeloid stem cells can differentiate into your RBC, your red blood cell, or erythrocyte. They can evolve into a mast cell. Mast cells, we will learn, produce histamine. Histamine. Mast cells are found in the skin, the scalp, the ears, nose, the respiratory system, digestive system, and we'll talk about the relevance of them shortly. But mast cells can produce histamine. Histamine is what is released as part of the inflammatory response. Many people that have allergies and get stuffy nose and swelling, right? That's a histamine reaction. Myeloblasts can evolve into basophils, eosinophils, and neutrophils, right? These are the three granular sites. You could see the granules here next to the nucleus in all three. And then we have the monocyte, which is agranular. And the monocyte is what can turn into a macrophage or a dendritic cell. These are typically referred to as antigen-presenting cells, or APCs. APC is an antigen-presenting cell, meaning it presents the antigen to the immune system and says, hey, this doesn't belong, attack and destroy. The other thing that the myeloid cell can differentiate into is platelets, and platelets are involved in clotting. So we will see all of these involved in inflammation and healing. So let's look at the what we just covered in more of a visual description, right? So we have our first line of defense, we have some fluids, we have our tears, we have saliva, mucus, even the stomach acid that we have is considered first line of defense. We have our skin that have the mucous membranes as well. So right here, this is the skin level. And again, these are non-specific, right? So non-specific could be the skin, mucous membranes, can also be the tears, the mucus, even the stomach acid. But we also have phagocytosis, the inflammatory response, and interferon. Now, these things here are involved with the second line of defense, meaning the first line, the skin and the tears and the saliva and the mucus, weren't enough to protect it, right? Although it's a barrier, let's say it broke through the barrier. You had a cut, you had a lesion, and now it broke through the skin. This is where we have phagocytosis, inflammatory, and interferon that kicks in, right? So the first line of defense didn't work. Now we have our second line of defense, okay? Our third line of defense is where we have our specific defenses. These were non-specific. Your third line of defense is specific, where we have our B cells that can produce an immune response. These little Ys, you'll typically see these Ys. These are antibodies. Remember, antibodies come from B cells that become plasma cells. Plasma cells produce the antibodies, whereas our T cells produce the cell-mediated and humoral immunity. The whole idea is that the main goal of all of these things is that we hope that all our defenses are enough to overcome the injury or the disease. Okay, capillary exchange. The normal circulatory exchange is important with inflammation. Capillaries respond to the metabolic needs of tissues, and capillary exchange is dependent upon, now you're going to hear these two words, hydrostatic pressure and osmotic pressure. When you hear the term hydrostatic pressure, I want you to think it's this pushing force. And when you hear osmotic pressure, I want you to think it's more of this pulling force. Pushing force versus pulling force. We're going to see the hydrostatic pressure being high more on the arterial side of the capillary, and we're going to see the osmotic pressure, the pulling force, higher in the venual side. And that's primarily because of the proteins and salts, so we'll show you that. So at the arterial end of the capillary bed, I'm going to show you a picture shortly, as you can see here. So on the left-hand side, right in here is the arterial side, and then in the middle we have the capillaries, and off to the right is the venule. So we can see that we have blood flow coming in, and then you can see right here there's a closed capillary sphincter right here, so it's diverting blood in this direction. Maybe there's an injury over here. So it's directing blood here in this direction. And what ends up happening is there ends up being this fluid shift that takes place, where blood cells, you can see we have a key on the bottom. We have blood cells, A for albumin, G for globulin, F for fibrin. These are all proteins. B is bradykinin, H is histamine, and PG stands for prostaglandins. So the B, the H, and the PG, these are these chemical messengers, if you would. So what's happening is we're going to have water that's pulled out, right, from the bloodstream, pulled out here, and in between these spaces we have cells. So you're going to have liquid pulling out, right? It's going to be pushed out because hydrostatic pressure is greater here than it is outside. So it pushes water and electrolytes and glucose outside of the capillaries to where we have these cells, and it's going to bathe these cells. We call that interstitial fluid. And then what will happen at the other end, we still have proteins that are remaining inside the blood, and there's proteins and there's some salts in here, and it will then create this osmotic pressure that's greater than the hydrostatic pressure, and it's going to pull, right, the pulling force, osmotic pressure, it's going to pull the liquid back into the venule system, into the veins, okay? So if we go back here, the arterial end of the capillary bed, you have blood hydrostatic pressure is greater than the interstitial hydrostatic pressure, meaning, again, the pressure here is greater than in these spaces. Okay, so it's going to push out. The fluids, the electrolytes, bloods, gases, and nutrients are pushed out of the capillary into the interstitial space. The formed elements, that's the blood cells and the plasma proteins like albumin and fibrin and globulin, they're going to remain in the blood. And these proteins have the ability, along with some of the solutes, they have the ability of pulling, creating an osmotic pressure, pulling back in. And that's what happens at the venule side. Okay, on the venous side of the capillary, the blood hydrostatic pressure is less than the interstitial hydrostatic pressure, and the blood osmotic pressure is greater than the interstitial tissue. So it pulls it back into the venule. So the fluids, the blood gases, and the waste products are pulled back into the capillaries. Okay, the fluids, not all of the fluid, right? It's not all of the fluid that was pushed out at the arterial end is pulled back in. It doesn't work that way. It's always less. Less fluid is actually pulled back in that was forced out in the first place, right? Okay, so Let's go back here and just review. So we have the arterial side. We have hydrostatic pressure being higher here than it is in the interstitial. But on this side, we have osmotic pulling force being greater, and it's going to pull the interstitial fluid back in. Is it pulling the same amount back in as was pushed out? No, it's always less. Okay, we're going to learn a little bit about bradykinin, histamine, and prostaglandins. What the histamine is going to do, it's going to dilate these vessels. It's going to open them up. Okay. All right, so if you want to take a pause here to review that, you can. Otherwise, we're going to move forward into the physiology of inflammation. So inflammation is a non-specific protective mechanism. And inflammation is the body's response to tissue injury. Okay? And it's normal. It is absolutely normal in an acute stage to have inflammation. It's always the first sign of healing. It's followed by heat, redness, swelling, pain, and loss of function. When something is injured, you can touch it. It's hot because there's a lot more blood rushing into that area due to the injury. And blood is 98 degrees, 97.6, right? It's hot. It's red because it's RBCs, red blood cells are in that area. It's swollen because maybe those capillary beds are damaged, and you have all that interstitial fluid accumulating that we just showed you in that little capillary illustration that we went through. And pain because of the bradykinin. The bradykinin and histamine are messengers of pain that tell your neural system, hey, we got an injury here. But pain is also a message to tell you, hey, maybe I'm not going to move that limb. I'm going to protect it and stabilize it for a bit. So inflammation, I would make sure you know all of these signs: heat, redness, swelling, pain, and loss of function. Disorders are named using the ending itis. So when something is inflamed, you can have a tendinitis. You can have an appendicitis. You can have a fasciitis. Okay? So anything that ends in itis is always some form of inflammation. And again, it's the normal part of the defense mechanism. Signs and symptoms serve as a warning for a problem, right? It's like a red flashing light: check engine, check oil, check tire pressure. It's letting you know that something is happening. Now, when something is inflamed, it doesn't mean it's not the same thing as an infection. Infection can be one cause of inflammation, but I've often seen people that get a little cut, and then, the parent looks at it and they, well, let's wash it. And they go, oh, it's infected. Look at it. It's red. No. Just because it's hot, it's red, and it's swollen, and it hurts doesn't mean it's an infection. Keep that in mind. This is the normal stage, the normal phases of things. So some of the causes of inflammation can be direct or physical damage, like you cut your skin, or you sprain a ligament, you sprain an ankle. It's going to be inflamed. Chemical exposure, being exposed to certain acids along that first line of defense, being exposed to drain cleaner and it touches your skin, that acid can burn. It's going to be inflamed. It's going to have to heal it. Ischemia, right? A myocardial infarction. Anytime there's lack of blood flow to an area can cause inflammation. Allergic reactions, being exposed to extreme heat or cold, foreign bodies foreign bodies that become exposed to your body and inject themselves, whether it be a piece of wood through a splinter or glass. The body always wants to find a way to push those things out. And infection. These are all different causes of inflammation. Now, the steps of inflammation, you're going to have injury to the capillaries that we just showed you before, and all the tissue cells. Now, when that happens, your body has to make you aware of it. So there's going to be a release of this chemical mediator called bradykinin. Bradykinin is released from the injured cells. And the bradykinin, when it's released, it's going to stimulate these pain receptors. There are some receptors for hot, other receptors for cold, some receptors for light touch and deep touch, and we have pain receptors. Now, the pain is going to set a cascade for another event, which is a histamine release. And histamine can be released from your mast cells and from basophils. Basophils and mast cells are like very close cousins. Mast cells, we have them all throughout our skin. You have them in your respiratory tract. You have it in your digestive tract, and they release histamine. Just think of people that have allergies. Sometimes they take an antihistamine, right? So that they're not speaking with a stuffed nose when they're all nasally due to the swelling in the nasal cavity. When someone consumes a food that they're allergic to, all histamines react. All mast cells react. So think of the mast cells in the stomach and in the intestines. The histamine reaction is going to make you run to the bathroom. It's going to dilate the colon and give the person diarrhea. The mast cells on the skin, a histamine reaction is going to make you itchy, red, hives, itchy scalp, itchy ear. You see kids with itchy tushes, right? They're always scratching their tush, a sign of allergies. And stuffed nose, right? That's a histamine reaction when people have sensitivities and allergies. Bradykinin and histamine can cause the capillaries to dilate. And when they dilate, what the histamine and bradykinin does, it just doesn't increase the blood flow, but it makes them more permeable. It makes them more leaky. So you've got a lot of this interstitial fluid accumulating and building up, which is part of the swelling component of healing. If there's a break in the skin and bacteria enters, that can be a cause of inflammation. That could be a problem. So then we have neutrophils that come in, those white blood cells, to help phagocytize the bacteria. And remember what macrophages are. They are monocytes that left the bloodstream and entered into the area that they were damaged tissues, and they start to phagocytose and eat the microbes. Now, there's acute inflammation and then there's chronic inflammation, right? So acute inflammation is good. Long-term chronic inflammation is very destructive and bad. So acute inflammation, the process of inflammation is really the same regardless of what caused it, whether it was a cut on the skin or a sprained ankle or an insect bite or a bee sting, right? The acute inflammation, the stages are the normal. The timing can vary with specific causes. So an immediate reaction would be you just sprained your ankle. Okay, if you sprained your ankle, swelling is going to happen pretty much right away. Okay, maybe it take a few minutes, but it's pretty much right away. But delayed would be a sunburn. That could take a few hours before you feel the phases. You don't feel it when you're at the beach right then and there, but the night and the next day, oh, it'll hurt. So the chemical mediators that affect the blood vessels and the nerves that are damaged, it's going to create vasodilation. So the vessels are going to become wider due to the histamine. When they become wider, there's going to be a lot more blood rushing into that area. That's called hyperemia, increased blood. And then there's going to be the increased capillary permeability as a result of the bradykinin and the histamine. When we need white blood cells to be drawn to the area and to walk along the walls of the damaged area, we call it chemotaxis. It's the ability to attract white blood cells, which are part of the immune system, to the damaged area. Okay? So the chemical mediators affect blood vessels and nerves in the damaged area by vasodilating. That's the bradykinin, right, and the histamine, creating more blood flow, hyperemia, increase the leaky capillaries, which is going to give you that swelling, the capillary permeability, and if there's an infection there, then we have the chemotaxis to attract the white blood cells of the immune system. Here's just some of the chemicals to be a little bit familiar with. You should know histamine. You're going to hear leukotrienes and prostaglandins shortly. I'm going to show you an illustration. These are kind of important. Kinins, you heard the word bradykinin before, okay? So this tells you the source, where they come from, And then here are the major actions of them. So you could take a few minutes on your own to review those. You may also hear the term cytokines. Interleukins, you may hear of like interleukin 6, interleukin 10. Interleukins are cytokines, and some cytokines are inflammatory, some could be anti-inflammatory, but for the most part, when we think of cytokines, we're thinking inflammation. So now if you look at a top, here's the skin, looks like there's a lesion, right, an abnormality to the tissue, some sort of cut. Now the cells are going to release the chemical mediators. You see the H for histamine, you see the B for bradykinins, and you see the PG for prostaglandins. And now you're aware of it because it hurts. Ouch. That's because of those bradykinins and prostaglandins and histamine. Because of the bradykinin and histamine and prostaglandins, now we have the vasodilation. So we can see that there's swelling that's taking place. But as a result, we know that these capillaries become leaky, right? So you have the albumins start to leak out. Now we have the fibrinogen starts to leak out. The water, the electrolytes and proteins, these things, due to the damage, they can leak out. And when they leak out, what follows the protein and what follows electrolytes and minerals and sodium? Always water. So it's going to move at an increased rate into that direction, and now that area becomes very, very swollen. You could see here the protein and water leave the capillary, and it forms what we call an exudate. That liquid, that interstitial that is increased, is called exudate. You see that right there, that term exudate. Now the lymphocytes, the leukocytes, the white blood cells, can move to that damaged area. And remember, the mechanism was called chemotaxis. And when you have these white blood cells or these macrophages that move in and these neutrophils that move in, it goes through that process of phagocytosis. So it can remove the debris. You can see the phagocytes are engulfing the debris here and prepares the body for healing. Now, in each cell, we have cell membranes that are composed of fats. Like you have different types of saturated and unsaturated fat in that cell membrane. We have phospholipids, right? Remember, the cell membrane is a phospholipid bilayer. And one of the type of fats that we have in there is called arachidonic acid. It is a polyunsaturated fat. And just like omega-3s are a polyunsaturated fat. And the difference is the omega-3s, polyunsaturated fat, tends to be anti-inflammatory, whereas the arachidonic acid that's in the cell membrane wall is pro-inflammatory. So arachidonic acid is metabolized to produce inflammatory mediators. Many current anti-inflammatory and pain medicines are designed to inhibit parts of this arachidonic pathway. So when you have an injury, arachidonic acid is pulled out of the cell membrane, and we have enzymes that can convert arachidonic acid into prostaglandins. And when they convert them to the PGs, the prostaglandins, you can get inflammation, pain, and swelling. So we have these COX-1 and COX-2 pathways. Just like there are many drugs that are COX-1 or COX-2 inhibitors that can block them. There were some old medications that were called Celebrex that people take for arthritis, and they end up being these COX-1 or COX-2 inhibitors that are designed to block the prostaglandins. Aspirin and ibuprofen is a COX-1 inhibitor. And when it blocks this, it can really help a person feel better because it's going to block the inflammation, pain, and swelling. But prostaglandins are not just bad. You need them. Prostaglandins help create a fever. And that's why when you take aspirin, your fever comes down. Prostaglandins help produce mucus in the stomach. You need mucus in the stomach, which protects the lining of the stomach against all the hydrochloric acid. If you have hydrochloric acid without mucus protecting the lining of the stomach, you get an ulcer. So people that take too much aspirin end up getting ulcers. Why? Because it blocks the mucus production of the prostaglandins. The natural hydrochloric acid that exists in the stomach eats right through the lining of the stomach. Okay? The other thing arachidonic acid can evolve into is something called leukotrienes. And when leukotrienes are being expressed, it constricts the airway. So it creates this asthma, this type of wheeze, airway obstruction. It is another component of inflammation. So it's either going the COX pathway to produce prostaglandins, or it goes the LOX pathway. See, the LOX is for the enzyme 5-lipoxygenase. So if you're blocking the enzyme by using these LOX inhibitors, then leukotrienes can't be produced. And that's when the people with asthma take these LOX inhibitors so that they don't get that asthmatic issue. Okay? What are some of the local effects of inflammation? Well, you get redness, swelling, pain, and loss of function. We saw that earlier on. Redness and warmth, why? And increased blood flow to the damaged area. Swelling, the edema, why? Because remember the shift of the protein and the fluid into that interstitial space? Yep. Pain, increased pressure on the fluid, on those nerves in that area. And don't forget about the bradykinins, which are pain signalers. Loss of function may develop if the cells lack nutrients. And then edema, that swelling, can also interfere with movement, right? When joints swell, think of a swollen ankle, you can't move it too much. Not at all. So you get loss of function. Here is an area, you can see it's hot, it's red. If you were to put the back of your hand, and this is important to know, that when you're assessing someone and you want to see if it's inflamed, if you want to check a child for a fever, you don't put the palm of your hand on the child's forehead. You put the dorsal surface, the back of your hand, on the child's forehead. It's much more sensitive on the back of your hand, the temperature. So this would be extremely hot, red, and swollen, and we'll see a lot of this when we cover some of the skin lesions here. But this is probably some sort of skin infection here. We could see a little bit of a blister on the inside there. And again, we can see how red and swollen this is. So we don't know what the cause of it is yet, but we can say that there is a degree of inflammation that's going on because it's red, it's swollen, and to the touch it may actually feel a little bit warmer. Now, we saw that word exudate a little bit earlier. That's the interstitial fluid that was pulled into that area that was inflamed. There's different types of exudate, right? Serous, fibrinous, purulent, and hemorrhagic. Serous exudate is a little bit more watery, consists primarily of fluid, some proteins, and some white blood cells. The fibrinous is thick. It's thick and sticky. Okay? There's a lot of fibrin in the area, which is designed for clotting. Okay? Purulent means pus. It's thick, yellowish, green, contains more leukocytes, more cellular debris, and some microorganisms. We'll typically see purulent exudate or pus associated with some sort of infection. When the body contains that infection, we call it an abscess. It's a pocket of purulent exudate. Years ago, I remember I couldn't even open my mouth. I couldn't stick out my tongue. I had some bad strep infection only on the back of my right tonsil. And I was really holding off on taking any type of antibiotics. I don't like to use antibiotics because I know the harm that they put on our mitochondria as well as the natural microbiome of the gut. So I try and just rely on my own body's mechanisms to take care of itself. So I felt it started off with a little bit of a sore throat, and then I saw I had a little bit of whiteness in the back there, so I knew that it was strep, but I figured my body would be able to take care of it. I'm nourished well. I do take care of my immune system. I have good nutrition, loaded up on some supplements. But it was during a very, very stressful time, and was also during the winter months, which is very cold. Also, lack of sunlight, low vitamin D, and eventually it got really, really bad. So I went to a local physician who I know, and she looked at it and said, "Say ah," and I couldn't even open my mouth. I couldn't even stick out my tongue. It was so painful. Just for her to shine a light to see it, um, she said, "Wow," and I said, "What?" She goes, "You have an abscess back there. It's walled it off." She said, "You're a very, very healthy individual. This strep did not spread anywhere. Your body actually contained it. So it's a pocket of purulent exudate." In which case, at that point, I did need to take a antibiotic because she said, the physician said to me, "Your body can take care of it as it has been, but if it ruptures and it leaks into other tissues, this infection can spread. And if it gets into the ear, it becomes much more complicated." And I said, I did the risk to reward ratio, and ended up using the antibiotic, and it did help greatly. But I gave the body its fair chance to take care of itself. All right, the hemorrhagic exudate is present when blood vessels break. Still, under acute inflammation, the systemic effects, now, right before we talked about local effects, right? So we have the accumulation of this fluid here more locally, but the systemic effects could be pyrexia, could be a mild fever. It's common if inflammation is extensive. It release of pyrogens from the white blood cells. You'll have malaise. Malaise is a common word that's just, they don't feel very well. They feel unwell. It could be fatigue, they could be headache, and anorexia. The term anorexia means lack of appetite. Now let's take a look at the course of fever. So you have this normal temperature, but then there's some sort of release of pyrogens into circulation. And what will happen is the body temperature will rise, right? You'll see there's a fever, but that information goes to the hypothalamus, right? Under the thalamus is the hypothalamus. The hypothalamus controls the autonomic neural system, sympathetic and parasympathetic, but it also controls body temperature, okay? So what'll end up happening is it'll reset the hypothalamus, and the body temperature will start to increase. As it starts to increase, you'll feel cold. There'll be shivering. There'll be vasoconstriction of blood vessels, so the person may lose their color. They may look pale. It's going to increase the basal metabolic rate. That's what BMR is, the basal metabolic rate. So the heart rate is going to increase, and they're just going to curl up into a ball to try and contain their body temperature, to keep it warm, because warmth kills pathogens, right? So eventually the body reaches this new high temperature up here. It stays pretty high. If it needs to go higher, then the body starts to go into spasms, right? You get these tremors. We call it a febrile seizure, in fact, where all the muscles contract really tight, because muscles, as they contract, generate more heat. You know that from exercise. Then you can treat to remove the pyrogens, and then the hypothalamus gets reset, and the body temperature starts to go down. Your blood vessels will dilate a little bit. You start sweating, so you start to lose that heat. It starts to cool off the body. The body still feels a little bit lethargic because it's still healing, still needs its energy, and the body's not curled up anymore, but the body is fully extended. When the body opens up, it can disperse that heat, and then the body turns back to normal temperature. Some of the diagnostic tests, you can do leukocytosis, right? If you look at blood work and the white blood cell count goes up, we call it leukocytosis, increase in the white blood cell count. Elevated CRP, you're going to see this quite a bit, C-reactive protein, and ESR, erythrocyte sedimentation rate. So with inflammation, the C-reactive protein goes up and the ESR can go up. and specific enzymes can be released from tissues. So some of the changes that we could see, again, you've got the increased ESR, the C-reactive protein. Some plasma proteins can increase, right? If we need to clot the area, then fibrinogen, which is inactive, anything that ends in ogen is inactive. When fibrinogen becomes fibrin, it allows to clot the area. And prothrombin comes before thrombin. A thrombosis is also a clot. Leukocytosis, an increase in the number of white blood cells, especially your neutrophils. A differential is a proportion of each type of white blood cell, right? So if you have an allergy, maybe your eosinophil count goes high. If your neutrophils go up, then maybe there's a bacterial issue. If your lymphocyte count goes up, then there's a viral issue. So depending on which cell goes up, it helps to direct as to what is the possible cause. Okay? And then cell enzymes, these are released from necrotic cells, right? As cells start to die, they become necrotic. Necrosis is cell death, and they enter the tissue, fluids, and blood. That can also indicate a local site of inflammation. What are the potential complications of acute inflammation? Well, infection, right? Microorganisms can more easily penetrate edematous tissue, which means swollen tissue. Why? Because the capillaries are very leaky, so things can enter and leave with much more ease. Some microbes can resist phagocytosis, and the inflammatory exudate also provides an excellent medium for microorganisms. Skeletal muscle spasming. Skeletal muscles become hard and stiff to protect an area that has become inflamed. So muscle spasms, stiffness and tightness can be a symptom or a complication of an infection. It is the protective response to pain. Now, chronic inflammation, opposed to acute inflammation, it usually follows the acute episode. There's less swelling and there's less exudate, but there's the presence of more lymphocytes, macrophages, and fibroblasts. And I said earlier that chronic inflammation is a really bad thing because it means you have continued tissue destruction for a long period of time, and then the surrounding joints and areas start to lay down more fibrous scar tissue. And when you have more fibrous scar tissue, adhesions or this gluey and stickiness takes place, and you start to lose function. Okay. A granuloma can also develop around a foreign object. You can get deep ulcers can result from severe prolonged inflammation, and this is caused by cell necrosis, right? It's caused by cell necrosis and the lack of cell regeneration that causes the erosion of the tissues. It can lead to complications such as perforation of the viscera, right? So if you have an ulcer and then it starts to perforate, it's not good, right? It leads to more systemic inflammation. So deep ulcers may result from severe prolonged inflammation caused by cell necrosis and the lack of cell regeneration. And you can end up getting perforation of the viscera or the organs. Now, moving away from, let's say, cartilage and joint inflammation and those localized tissues for chronic inflammation, there is some new science that shows that most of these diseases, like on the top at 12 o'clock, neurological disorders, Alzheimer's, dementia, neurodevelopmental disorders, moving around to 1 o'clock, IBS, pancreatitis, psoriasis, rheumatoid arthritis at 3 o'clock, diabetic complications, neuropathy, cardiovascular disease. Around 5 o'clock, metabolic disorders, fatty liver disease, diabetes, metabolic syndrome, 6 o'clock, fibromyalgia, neuropathy, 7 o'clock, cancer, gastric and colon issues, breast issues, prostate issues. At 9 o'clock, clinical depression, bipolar, schizophrenia. 11 o'clock, stroke, heart failure, atherosclerosis, that all of these things are a byproduct of chronic inflammation. Just about every disease out there is an inflammatory type of disease. And we can try and limit and down regulate the amount of chronic inflammation, and lifestyle can help us do that. Foods can also help do that. Foods can make your body more inflamed. There are certain foods that are more pro-inflammatory, and there are certain foods that have an anti-inflammatory effect. So just like if you had some joint inflamed and it was hurting, you could take an anti-inflammatory. Certain foods can make it worse. So why wouldn't a good physician or doctor or healthcare provider advise someone, hey, you are acutely inflamed, let's try and stay away from these pro-inflammatory foods, or hey, you have a chronic inflammatory condition, let's focus more on an anti-inflammatory type of diet. So in terms of the course of inflammation and healing, so we have some sort of tissue injury, and in the very beginning, you've got acute inflammation. So you're going to have the release of these chemical mediators, histamine, kinins like bradykinin, and the prostaglandins, the PGs. And some prostaglandins are pro-inflammatory, and there are some that are anti-inflammatory. They're not all bad. But when you do take a prostaglandin inhibitor, it kind of blocks them all. So as a result of the histamine, you get the vasodilation off to the left, increased blood flow, so it's hot and red. With the histamine, you get the increased capillary permeability. And with the kinins, the bradykinins, you can get pain. So you get edema, swelling, and pain. And then with the histamine and the prostaglandins, you get chemotaxis. Now you got white blood cells migrating to the area. And with the bradykinins, you get irritation of the nerve endings. You get pain. So what's going to end up happening when you get that increased capillary permeability, we want it to clot. We don't want it to leak. We don't want that injury to get worse. We have clotting and fibrin. They start to get in that area. If you had a cut or a lesion, we don't want it to bleed forever and ever and ever, but enough blood to flush and push out any debris from the lesion and push it out. And then eventually fibrin will help wall off and clot that area. But the white blood cells, the chemotaxis, can help with the phagocytosis and removing any cellular debris. Then the preparation of healing, if it's moving in a healthy direction off to the right, great, it heals. You get regeneration, maybe a little bit of scar tissue, not too much, but it's resolved. There's resolution. Otherwise, you get chronic inflammation, right? If that feedback loop doesn't kick in and it knows to stop, then it just overheals. It keeps staying in this chronically inflamed state, and the tissues keep breaking down, and overhealing, breaking down and overhealing, and you get scar tissue that forms. And that creates fibrosis, which limits function, right? Creates adhesions, and things start to stick and glue. So what can people do for inflammation? Well, some people use acetylsalicylic acid, which is aspirin. That reduces the prostaglandins. Remember, prostaglandins can create fever, pain, swelling. It produces mucus in the stomach to protect it. So if you take aspirin, it blocks all of that. Acetaminophen is what we refer to as Tylenol. It's a fever reducer and pain reducer. It doesn't work great in the inflammatory response, but it works really good with fever. The NSAIDs, NSAID stands for non-steroidal anti-inflammatory drugs. These decrease inflammation, pain, and fever. An example of this is ibuprofen, like Advil, Aleve, Motrin. These are really good NSAIDs, non-steroidal anti-inflammatory drugs. Really good for short term. Long term, they can result in quite a few issues. Corticosteroids, these are steroidal anti-inflammatory drugs, not non-steroidal. These will block the immune response. So they reduce inflammation. They're used short term due to many adverse or unwanted reactions. But there are some beneficial effects of these corticosteroids. They stabilize the vascular system by decreasing that capillary permeability. right? If you decrease capillary permeability, you're decreasing inflammation. The problem with decreasing inflammation, in the short term it's good, but long term, inflammation is the first sign of healing. Although the pain and discomfort may go away, it never does truly heal. So you have to be really careful with corticosteroids. The enhancing the effectiveness of epinephrine and norepinephrine. Epinephrine and norepinephrine, remember, these are the chemical messengers like adrenaline and noradrenaline. These are the chemical messengers associated with the sympathetic neural system. And when you have epinephrine and norepinephrine, the blood vessels vasoconstrict. They don't dilate with inflammation, they constrict. So you get the reduced number of white blood cells or leukocytes and mast cells. And remember, if you have decreased mast cells, then you have decreased histamine. So you get this reduced immune response, thus reducing inflammation. The adverse effects of corticosteroids, you get atrophy of the lymphoid tissue, which means there's going to be reduced hemopoiesis, meaning decreased blood cell production, especially white blood cells. If we're talking about atrophy, which is the decrease in size of lymphoid tissue. So now you got the decrease of your WBCs or your white blood cells, which means increased risk of infection, because where's your army? Where's the army that's going to help you? Catabolism, right, means breaking down. Catabolic effect, the increased tissue breakdown, decreased protein synthesis. We have seen in the past many professional athletes that have these injuries and they take these corticosteroids. When they take them too often, these are the ones with the chronic hamstring pulls, the torn Achilles tendons, the rupturing of Achilles tendons. So long-term, very bad. We know that they delay healing. It can affect and delay the growth in children. High blood pressure from the sodium and water retention. You'll start to see people, their faces balloon up and they get very watery looking and puffy looking, and they get high levels of glucose. So you have to be really careful with the overuse of corticosteroids. Researchers from the Department of the Orthopedic Surgery at the University of North Carolina, Chapel Hill, they found that COX-1, naproxen, and COX-2 NSAIDs like Celebrex delayed healing in the knee tendons of rats that were injured surgically. And the rats were given Celebrex had the lowest load-bearing capacity of any animal. NSAIDs prevented healing by decreasing the collagen content. Remember, collagen is a protein. 1/3 of bone is collagen, muscles, tendons, skin, collagen. Other studies found that COX-1 and COX-2 drugs delayed fracture healing. So, this was from the American Journal of Sports Medicine back in 2007. So have to be really, really careful. NSAIDs have their great benefit for pain management, but they can slow the rate of healing. So this is just a chart that shows the comparison of drugs used to treat inflammation, whether they're anti-inflammatory, right? So you look at the acetaminophen, NSAIDs, glucocorticoids, COX-2 inhibitors, and aspirin, and you could see whether or not they have anti-inflammatory effect, analgesia for pain, if they can help with allergies, GI distress, stomach ulcers, MIs. So you can look at this chart on your own time there. In terms of treatment of inflammation, when there's an immediate structural and functional issue to any localized joint, we would say RICE. Rest the area, ice the area, compress the area, and elevate. RICE. Rest, ice, compress, and elevate. This is in the initial and early stages, right? In that acute stage. Good place to pause. We covered a lot of information, so if you want to pause here, please do. Otherwise, if you'd like to move on, here we go. The types of healing. Resolution. Well, what does that sound like? To resolve, right? There's minimal tissue damage. The damaged cells recover, and the tissues return to normal. An example of that would be a sunburn, a resolution. Regeneration. Well, what is regeneration? It sounds like the opposite of degeneration. This is when the damaged tissue replaced with cells that are functional. Epithelial tissue, if you remember back, epithelial tissue is exposed to a lot of irritation, and it has the ability of replacing itself pretty quickly. Your skin is epithelium. We know that the skin, you can get a scratch or the stratum corneum can slough off, but we make new cells. It goes through mitosis, which is cellular division. It replaces the damaged cells. So an example is a minor cut to the skin, right? After it regenerates, you're unable to see evidence of the cut. And that's if it's a minor cut. If it's major, okay, maybe you'll see a little scar. Replacement, still different types of healing. The replacement could be primary or secondary intention. Okay, the functional tissue is replaced by connective tissue. It takes place whenever there is extensive damage. The healing by primary intent takes place when the wound's edges come together. Very, very little scarring with this. Compared to secondary intention, a much wider lesion, will be a larger gap between, and it's going to result in greater scarring. This is why when there's a large gap, getting to a physician, maybe they need to stitch the area to bring the two sides close together to try and limit that gap. So here, healing by first intention, you can see on the top there, you've got that injury, you've got inflammation. You can see you've got some collagen fibers in here, you've got some neutrophils, you've got inflammation, the blood is trying to clot in that area. And slowly but surely, we start to see that there's a little scab that's trying to form, which is the clotting of all that blood. Now you've got granulation tissue and epithelial tissue growth. So you've got epithelium in the skin. We know that there's 5 layers of skin, and it's still a little bit inflamed. Now you've got some macrophages here. It's going to go through phagocytosis to engulf any cellular debris or maybe any bacteria there. We still have the formation of granular or granulation tissue, and you can see you got new blood supply here. You've got some new capillaries that are starting to form. You see the healthy blood vessel. You see a little bit of a scar. We could see a little bit of discoloration. Why? Because this is new epithelium, right? The melanin hasn't really tinted the skin to match both sides of it, right? So you may be able to see it. But this is healing by first intention. Second intention, you can see the lesion is a lot greater, right? You can see the lesion is huge, but then here, even that gap, you see there's a large scar that remains here. That's healing by second intention. You can compare both of these back to back and see the difference. The healing process, blood clot starts to form. It seals the area. Inflammation, we saw, also develops in the area. The foreign material and cellular debris is removed by the phagocytosis and macrophages. We saw granulation tissue fill in that gap. We saw the new capillaries that start to develop in the area. We saw the epithelial cells divide, right? Mitosis, and it covers that wound area. Fibroblasts were there, and they begin to produce collagen. Collagen is a really important protein. You find it in the skin. You find it in the skin, hair, nails. Bone is 1/3 collagen. In order to produce collagen, you do need vitamin C. And think of what happens when the body's under lots of stress. We burn up vitamin C. And we can't manufacture vitamin C. If it's not in our diet, we're depleted. So if you want to have good collagen production, you need good, healthy vitamin C. If you look at chronic smokers, people who've been smoking for a really long time, you can see on the face a lot of wrinkles. The integrity of the skin does not look as healthy. That's because the smoking depletes vitamin C, plus the stresses in the world depletes vitamin C. So we have always heard stress kills, right? Vitamin C is needed to produce collagen around blood vessels, skin, hair, nails, bones. Very, very important to have good collagen. Factors that promote healing. Hey, look, we know younger people heal faster than older people. You need to have good nutrition. Eating refined carbohydrates and eating food that comes in boxes and bags all the time isn't the healthiest. You want to have a good balance of real food, real nourishment. Things that come from trees or things that grow up from the ground or things that come from animals. That is the best food sources out there. Um, Having good blood supply, good adequate hemoglobin, which means good oxygenation. You need good blood supply or circulation. You need to have clean wounds, right? Hygienic. You want to eliminate any possibility of infections and having no repetitious trauma at that site, right? You want to rest the injured area to promote healing. And the factors that delay healing are pretty much just the opposite. Advanced aging, poor nutrition, not consuming enough hydration. The only liquid we really need to consume is water. And again, the general rule of thumb is divide your body weight in half and drink that amount in ounces. And it should always be mineral water. People that are anemic, because they have low red blood cells, if you have decreased red blood cells, you can have decreased oxygen. And you need oxygen for energy. You need energy to heal. Circulatory problems. Anytime there's a blood clot or atherosclerosis or decreased blood supply, which is what we call ischemia, decreased blood supply to an area, there's going to be a problem. Not just decreased oxygen, but decreased nutrients getting to the area will be a problem. Presence of other disorders like diabetes, people with diabetes or high blood sugar. High blood sugar is toxic to neurons, to blood vessels, to the eyes, to the kidneys, to the skin, and tend to have compromised immune systems. What else? Excessive mobility, meaning if you're not resting it enough. Infection or foreign objects could be a problem that delays healing. Chemotherapy, prolonged use of corticosteroids also decrease healing time. I remember a few years ago, I was having such hip pain deep in the acetabulum. And I had a labral tear in my acetabulum, and very quickly that labral tear increased in size. So initially they gave me a corticosteroid shot in the actual joint itself through video fluoroscopy, where they can actually see the needle go into the joint, and it went right there. Within seconds, the pain was gone immediately. But I knew that there was a serious underlying condition, and that corticosteroid was just buying me time to find a resolution. And the orthopedist told me that that injection should last me 3 to 4 months. It only lasted about 3 to 4 weeks, and the pain got worse. And every time I took a step, the degree of pain was just so bad. I went on a trip. I was gone for about a month. By the time I came back, that 4 weeks have lapsed. When I came back, I went for follow-up imaging, and the tear got worse. And now the head of the femur was hitting my acetabulum, and I was getting these bony fractures, which is why the pain increased severely. Went back to the orthopedist, asked for another injection. She said she would do it, but advised me against it. I said, why do you advise me against it? She said the corticosteroid will delay the healing time, and if you get an appointment for surgery, your doctor will not do the surgery because you won't be able to heal properly. So we didn't do the injection. We dealt with the pain, and I had to deal with it for a few more weeks until the Hospital for Special Surgery in New York City was able to see me and was able to do a hip resurfacing. Not a hip replacement, but a hip resurfacing, which is taking the head of the femur and smoothing it out, cutting off about, I would say, a third of the femoral head, and they put a cap on it. And then the female end is also a metal receiving end. So the complete ball and socket is metal against metal, but it's titanium and a little bit of chromium and some nickel, things of that nature. And went to the best orthopedic surgeon in the nation, and he teaches this procedure called a hip resurfacing. And thank goodness, because now the hip is brand new. There's no restrictions. Took me quite a long time to heal, but absolutely no restrictions, full range of motion, and so happy I did it. So loss of function, um, these are what ends up happening if you have a complication from scar formation. Um, Sometimes things can overheal, and then you start to get these adhesions, which are bands of scar tissue that join the two adjacent surfaces together that should be typically separated. So loss of function results of the loss of normal cells and the specialized structure. Maybe you won't see the hair follicles come back, the receptors may be gone, nerve endings may be destroyed. So you'll have loss of function from that. Contractures and obstructions, because keep in mind when scar tissue forms, it's non-elastic, so it's going to restrict movement. And then these adhesions is this gluiness or stickiness, so you're going to have decreased range of motion. You can get this hypertrophic scar tissue where you get this overgrowth of fibrous tissue and it leads to hard ridges of scar tissue. And we're going to show you what that looks like. You can also see a keloid that develops. So we'll show you the difference between what hypertrophic scar tissue is or a keloid. It is quite obvious in its difference. And ulceration can be a complication. The blood supply may be impaired around the scar, resulting in the surrounding tissue can break down even further, creating an ulcer. So here's your hypertrophic scar, hypertrophy, that's hypertrophic. When we take this to a whole new level, this is what's called a keloid. Now sometimes they'll try and do a procedure to remove this, but then a scar has to form to heal that, and it usually comes back. Here on the left, we have a normal esophagus. Here's the stomach. Here's the diaphragm, the diaphragmatic hiatus, so the opening allows the esophagus to meet the stomach. Sometimes you'll get a hiatal hernia where you get part of the stomach pulled up against the diaphragm. And keep in mind, the stomach is acid producing, so you start to get this acid that moves up the esophagus and you start to destroy and damage the epithelium, and you can get scar tissue that forms here. As the scar tissue forms, it can narrow the lumen, right? We call that stenosis or narrowing. That's another problem of scar tissue. Scar tissue can also twist and bind the colon, so it leads to improper digestion. It can also lead to constipation and the inability to remove or eliminate toxins from the body. Types of burns. We're going to talk about first, second, and third degree burn, but burns can happen from thermal, chemical, radiation, electrical burns, light burns, and even friction burns. Thermal burns are obviously caused by flames or hot fluids. Chemical could be like Drano, any type of acid. You can get burns from excessive radiation, electricity, electrical burns, light burns, and even from excessive friction. Your first degree burn is known as a superficial burn or a partial thickness burn. Primarily involves just this layer here, the epidermis. It is red, it gets painful. Your typical sunburn is a good example of a first degree burn. Usually no blisters form here. And this can heal pretty easily without any type of scarring. You just get a little reddening up at the top with a superficial burn, right? There's your sunburn. Your second degree burn is considered a partial thickness. Now it goes through the epidermis into the deeper layer, into the dermis. This gets red, it gets edematous. You do have edema in that area because you do have blood vessels in the dermis. You don't have blood vessels in the epidermis, but you do have capillaries and blood vessels in the dermis. This blisters and becomes painful. Can also become infected, causing additional tissue destruction and scarring. So second degree burns are very painful. You can see you get a little blister that's forming here. Here's a few examples and pictures of the second degree burn. You can see the blisters forming. It's through the epidermis. You see some blood, so you got some dermis. That's your partial thickness burn. Your third degree burn goes through the epidermis, down into the dermis, and you have destruction of even nerve endings here, okay? So this one is sometimes less painful oddly enough, it's certainly more dangerous and life-threatening, but sometimes less painful because the nerve endings are actually destroyed. So when it goes deeper, even into the hypodermis or the subcutaneous down here where you have the fat cells, that could be considered a fourth degree burn. Okay? And here the damaged tissue is going to shrink. So that's your full thickness burn. Through the epidermis, into the dermis, right down into the adipose, which is the subcu or the subcutaneous. And here it looks like it's getting a little bit into the connective tissue down here at the bottom and into some of the muscle. Here's a full third degree, full thickness burn, right? You can see all the necrosis, all the blackening and hardening of the tissues. So what are the effects of the burn and the injury? There's some local effects and systemic effects. Shock is a biggie. Shock happens with large burn areas of inflammation because it causes this shift of fluid into the area. When you cause a lot of blood shifting into one area, it's going to decrease the blood volume and the blood pressure to other parts of the body. And this is when people go into shock and they faint, because it's easier to pump blood back into the brain. If you faint and you're lying horizontal, it's a lot easier to get blood to the brain that way than standing, pumping blood back up to the brain when you're vertical. Respiratory problems can result from inhaling toxic fumes or irritating fumes. You can damage the trachea. You could damage the mucosal membranes of the respiratory tract. Remember, that's first line of defense. Pain is another effect. The actual healing and treatment of burns is very, very painful. Infection, due to loss of that first line of defense that we spoke about, it can increase tissue loss. Immediate covering of a clean wound is very important to help keep it sanitized. You want to make sure that there's no bacterial or any type of fungal infection that can cross that first line of defense. There's going to be increased metabolic needs for the healing period. That's because the increased energy requirements that are needed to repair tissue. So healthy, healing, colorful foods. Stay away from the whites. Stay away from white flour, white bread, white sugar. You want to stay away from that. The patient should increase the intake of protein and good, healthy carbohydrates during that time. Carbohydrates for good energy and fuel, protein for the collagen, for the amino acids, for the tissues to heal up. This is a nice illustration that shows the rules of 9. You can see that the upper torso is 9% of the body. The abdominal region is 9% of the body. The upper thigh is 4.5%, lower leg 4.5%. So when you add these up together, you have 9%. You can have the front of the arm is 4.5%, plus the back of the arm 4.5%. So each limb, upper extremity is 9%. When you look at the front of the face, it's 4.5%. The back of the head, 4.5%. So the total is 9%. The two arms are 18%. The front, which is 18%, the back is 18%, so the trunk is 36%. You have 9 in the front, 9 in the back, that's 18. 18 and 18 is 36%. And you have the genitalia, which is 1%. When you add them up, you get a total of 100%. And this is how we calculate what percentage of the body is burned. Healing is a prolonged process. The area has to be cleaned. It's got to be covered to protect it from infection. And in certain instances, we could use grafts, which is a technique that's used to cover the area. It can be cultured from the burn patient themselves. It can take several weeks for that to grow. Sometimes they use pig skin or cadaver skin that could be used temporarily. And in many instances, it's synthetic skin, which are substitutes that are used in large burn centers. And here you can see are just a few examples. Infections in a burn wound. On the left-hand side, there ends up being a little bit of a purulent exudate, which can be cultured to identify if there's any microbes there. In B, there's some blue greenish over here that indicates an infection by Pseudomonas aeruginosa. Okay. And sometimes that can create that gaseous necrosis. Okay. Scar tissue develops even with skin grafting. We showed you the hypertrophic scar tissue that's common. And to try and decrease the negative effects of scar tissue and fibrosis, we could use physiotherapy, we can use chiropractic, we can use occupational therapy. All of these have the same goal to reduce the effects of scar tissue and try and restore normal function. You restore normal function by allowing to restore normal structure. Structure determines function. Surgery may be necessary to release any type of adhesions or restrictions or fibrous scar tissue. And that brings that lecture to a close.